So, good evening, friends. Welcome to this live session of DocTutorials on RRM. I'm Dr. Vikashini here to discuss about the NESS questions, the general surgery part, which appeared in the NESS November 23. So it's going to be a detailed session. So without wasting much of our time, let's jump into the discussion part. So first one, what is the grade of Clavian window classification for infected wound opened at bedside? So it's a bit direct question. So here in Bailey 28th edition, you have this tabular column in page 318, which gives you this classification. See, complications after surgery are quite common. And this Clavian window classification, in this, the complications are graded based on the treatment they require. And here the observations are made objectively, thereby it avoids all those subjective biases. So let's get into the details. Like here is grade 1 is like any deviation from the normal postoperative course without the need for any pharmacological treatment or any other surgical or endoscopic or radiological interventions. But there are certain drugs that are being acceptable to give in this grade, and that includes antiemetics, antipyretics, analgesics, and diuretics, electrolytes, and physiotherapy. All these are included in grade 1. And also here we have the answer for our question. Yes, this grade also includes the wound infections which are being opened at bedside. So we got the answer. And let's also discuss the other grades. Yeah. Grade 2 is like with those requiring the pharmacological treatment with drugs other than which were mentioned in the grade 1, like antibiotics and also blood transfusions, total parenteral nutrition, all these things. And grade 3, it includes like those complications which require surgical, endoscopic, or radiological interventions, and it's again subclassified as 3A and 3B. 3A is those interventions which are not done under general anesthesia, and 3B is those interventions which are done under general anesthesia. Now, grade 4 is, it includes life-threatening complications, and that includes brain hemorrhage, and also it requires ICU management. And it's again subclassified into 4A and 4B. And 4A is like if there is any single organ dysfunction, and that includes dialysis for AKI or complete renal shutdown. And 4B is if there is any multi-organ dysfunction. And if there is a death following any complication, and that is classified as grade 5. So again, it's a direct question. So it's grade 1, which is the infected wound opened at bedside is grade 1. The next is, which of the following is not a component of revised cardiac index? So which of this following is not a component? So hypertension, diabetes, renal insufficiency, or a history of stroke. So here we have index called as the revised cardiac risk index of Lee. Now it predicts the risk of cardiac events in a patient who undergoes a major elective non-cardiac surgery. And it has around 6 clinical predictors, and each of which are given equal weightage. So let's see one by one. So any patient with previous history of ischemic heart disease and a history of prior heart failure, or any history of cerebrovascular disease, or if a patient is a diabetic, or he is having a renal insufficiency like a creatinine of more than 177, or which is creatinine of more than 2 milligram per deciliter, or any other high risk for surgery. So all these are included in this risk index. So in the option, we had diabetes mellitus, renal insufficiency, and also history of stroke, so which is a cerebrovascular disease, but not hypertension. So hypertension is not included. It's not a component. Again, it's a direct question. And let's see how it has been inferred. If the patient is not having any of this complication, then the risk that he might develop a cardiac complication is just 0.4. But if he has one of these 6 factors, then he'll be having a 0.9% of cardiac events. And if he has 2, then 7%. Of 3 or more than 3, then the probability that he can develop a major cardiac complication is 11%. So that is how it is inferred. So which of the following is not a component? Hypertension. Next is surgical classification for old trauma wound. So old traumatic wound is included in which class? That's a question. So here this clinical disease control have given us a tabular column in which this old trauma wounds are included in dirty infected wounds. So let's get into this some more details of it. So the clean wounds, which are also classified as class 1 wounds, here they have no infection. Like prior to the incision, we put there is no risk of infection, or there is no microorganisms that pose any threat to cause infection. So that is what is classified as class 1. And here the only skin microflora are the only potentially microorganisms that can contaminate the wound. And here we don't open any hollow viscous tract like GIT or respiratory tract. And 1D, this is for an additional information that it is just similar to class 1, but except that you introduce a prosthetic device into it. For example, mesh or valve. So if in that case, even though it is a clean wound, it's classified as class 1D. So it takes its reference in Schwartz 11th edition, page 169. And clean or contaminated is a class 2 wound. Here, the hollow viscous like respiratory tract, GIT, gut, all these which have some native bacterial flora are being opened under controlled circumstances without any much spillage of the contents. And class 3 is a contaminated contaminated wound in which the open accidental wounds, they are encountered at an early stage. So these trauma wounds are addressed at an early stage. And this is classified as contaminated, that is class 3 wound, because of the introduction of the bacteria into a normally sterile area, because of the major break in the sterile technique. And a very good example for this is an open cardiac massage that is being done in the emergency room. And class 4 is a dirty wound. And here it comes the trauma wounds in which there is a significant delay in the treatment has occurred. And also it has some necrotic slough into it. And it's also evidenced by the presence of pus material or purulent material. So again, it's a direct question. So the answer here is the old trauma wounds are included in class 4. And it takes its reference in all these books, Schwartz, Sabiston, and Bailey and Love, recent editions. Okay. So next is, what is the child Puck classification of this patient? So basically, you're given with the values, all this values of these parameters that are being included in the CTP. You just need to calculate the score and classify it accordingly, like A, B, C, or D. So the bilirubin is 50 micromoles per liter. Albumin of this patient is 35 gram per liter. And INR is 1.89. And patient does not have any ascites or encephalopathy. So you all know this CTP classification, which gives you the hepatocellular function in cirrhosis. But you don't want me to read it out, I guess. So the patient's bilirubin was 50, so he gets a point of 2. And albumin of 35, again, he gets a point of 2. And INR was around 1.89. So again, he gets a point of 2. So totally 2, 4, 6. But here you should not miss out ascites and encephalopathy. Even though the patient does not have ascites and encephalopathy, he gets a score of 1 for each. So it's 1 plus 1. So 2, 4, 6 plus 1 plus 1. So totally it's 8. So it belongs to this class of B. So now what are the limitations of the CTP classes? That you all know that hepatorenal and hepatopulmonary syndrome are the contraindications for a liver transplant surgery. But in given that circumstances, this CTP classification does not take into account any renal function. It does not include any renal parameters or lung parameters, right? And also it is the assessment of ascites, like whether it's a mild, moderate, or severe. All these are subjective assessment. So to overcome these limitations, there was another score called as MELD score, which was which is nothing but it's a model for end-stage liver disease, and it's used to assess a long-term prognosis with cirrhosis, and also it prioritizes the candidates for liver transplant. So the formula, I'll give you this, but I just want you to remember what are the parameters that is being used in calculating this MELD score. It's just bilirubin, INR, and creatinine and sodium. So all these are the parameters that are being used in calculating this MELD score. So here in this tableau column, you can see that if the MELD score is more than or equal to 40%, then the probability that the patient will die, or like the mortality rate at the end of 3 months is just like it's very high, right? It's 71.3%. So yeah, the parameters are sodium, creat, bilirubin, and INR. So again, coming back to the question. So we calculated it as 2, 4, 6 plus 1 plus 1. So it's 8. So it belongs to CTP B classification. Yes. Not a criteria for damage control surgery. So which of the following is not a criteria for damage control surgery? Yes. Whether it's an injury severity score of 38 or blood pressure of 80 and 60, pH of 7.1, and serum lactate 7. So in which of this following is not a criteria? that you don't take a patient for a DCS. Yes. Basically, the goals of DCS are to stop any active bleed and control sepsis and to restore the physiology. And you have certain indications like anatomical indications, physiological indications, and environmental indications upon which you take the patient for DCS. Now, the question was basically, most of these options are from the physiological indications. So let's get some insight into the physiological indications for DCS. So if a patient is having hypothermia of temperature less than 34 degrees Celsius, or if the patient's pH is less than 7.2, so the option there was 7.1. So yes, it is definitely an indication for DCS. Again, next is serum lactate of more than 5. So normally it should be of less than 2.5 millimoles. And in the option we have 7, right? So again, if it is more than 5, you should take the patient for DCS. And the other physiological indicators include prothrombin time of more than 16 seconds, partial thromboplastin time of more than 60. And if the patient had required more than 10 units of blood in a single day, and if the BP is less than 90 mm, especially the systolic BP is less than 90 mm for more than an hour. So again, it was given as 80-60. So all these 3 were given in the option. So the odd one out was the injury severity score of 38 is not included. So you got the answer, but let's see the other indications of DCS, like as I already mentioned, there was anatomical. Yes, if a patient is hemodynamically unstable, or if you have to operate on the patient's liver or pancreas, or if there are any combined injuries like thoracic and abdominal injuries, or neuro like CNS injury, brain injury, or if there is a demand for non-operative control of other injuries like a pelvic fracture, and if the anticipated need for the need is like you need a more time, it's the procedure you have planned to do needs it's going to be a time-consuming procedure. So all these are anatomical indications where you take a patient for DCS. Coming to the environmental, again, so in physiological indication, we saw that if the patient is of a hypothermia of less than 34, you have to take him for DCS. But here, see, if the operating time is more than 1 hour, then it automatically reduces the core temperature. That is, the core temperature of the body is lost by 2 degrees Celsius. So this again adds or supplements this hypothermia. But all this hypothermia, what will this cause? It will deactivate or inactivate the clotting factors. So it will be very difficult for us to control the bleeding. So if the anticipated need is more than a hour means, then you should just plan on a damage control surgeries in such cases. And if there is any inability to approximate the abdominal incision, so because of those toxic fluids which entered into the peritoneal cavity, or if there is any bowel edema, so which hinders you from closing this abdomen, then you can just temporarily use this temporary abdominal closure method, and then you can after those fluid have got reabsorbed and physiology has been restored, you can plan on this definitive abdominal closure or any definitive surgery. And if you desire to reassess the intra-abdominal contents later on, say for later on after 24 hours, so in such case also you can plan for this temporary abdominal closure. Now there are stages in DCS in which the first stage is patient selection, like you select the patient depending upon the indication, and second is you control like the goal. You have to achieve the goal of bleeding control and sepsis control, and then shift to ICU, resuscitate and restore the physiology. And fourth stage is you plan for the definitive surgery, and finally fifth stage is to plan for the definitive abdominal closure method. So this is this temporary abdominal closure where this inner abdominal contents, you have an inner layer where the abdominal contents are being closed with the offside dressing, and then you put in some abdominal swab and cotton drapes. So this space also gives you some space where you can put a suction drain. And again, over that, you can close it with another layer of offside. So it's basically a sandwich of inner and out, a sandwich of offside dressing, where the inner and outer layer are offside dressing. And in between, you have the swab and the cotton drape with suction drain placed in it. So after reabsorbing all this edema, you can just plan for the closure. So which of the following is not a criteria? Yes, it's the option A, which is injury severity score of 30. It has not been included as a criteria for damage control surgery. Again, it's a very simple question. Class of shock for blood loss of 20%. You just need to know the percentage of the blood lost and what is the class of shock. So this is this traditional classification of hemorrhagic shock given in your Bailey, even in recent edition, so 21st edition. Yeah, if the loss is less than 15%, then sorry, it's Bailey 28th edition, I'm sorry. Yeah, so if the loss is less than 15%, it's class 1 shock. And if the loss is between 15 to 30%, so in the question we had 20%, right? So it's obviously class 2 shock, and 30 to 40 is class 3. And if there are more than 40% loss, it's class 4 shock. So see, class 1 shock is very much similar to a blood donation, so it doesn't make a big deal. But let's see this class 2, 3, 4 shock, which are mild, moderate, and severe shock. So in mild shock, like here the mild blood loss, like 15 to 30% of the blood is lost, but this blood loss can be compensated by our body. So you know that cardiac output is nothing but a stroke volume into heart rate. So when your volume is lost, your heart rate compromises for it, right? All this happens with the help of a RAS system, that is renin-angiotensin system, which releases adrenaline and that acts on the heart to increase the rate of the heart. So that way heart rate increases. That is why this tachycardia happens. But by doing all this, the cardiac output is maintained. So because cardiac output is maintained, the renal perfusion is maintained, everything is maintained. So BP is normal. Because BP is normal, so everything is compensated, right? So class 2 or shock, which is a mild shock, it's also called as compensated shock. Slightly, the patient will be anxious. That's it. That is coming to this moderate or class 3 shock and a severe shock. See here, again, the body cannot compensate for the lost blood, so there will be a mild hypotension with tachycardia and tachypnea. And also because there is decompensation happening here, so the output reduces, there will be oliguria, and also the patient will be drowsy but arousable. Whereas in severe shock, where there is more than 40% of blood loss, there is a complete renal shutdown. See, there is no compensation happening at all. Severe hypotension ensues, and there is tachypnea, tachycardia, because of reduced blood supply to this respiratory system. There is labored breathing, and comatose. Patient is comatose, and complete renal shutdown with zero output, which is anemia. So both this class 3 and 4 shock are also called as decompensated shock. So straightforward question. So blood loss of 20% is class 2. Which of the following is the contraindication for sentinel lymph node biopsy except? So there are double negatives here. So basically the question is, which of the following is not a contraindication for sentinel lymph node biopsy? Whether it's a breast scarring or history of breast radiotherapy or inflammatory breast cancer or T3 disease. So again, it's a direct statement from Bailey, which states that the sentinel lymph node biopsy is contraindicated in inflammatory breast cancer and in those with T4 disease and a history of previous breast or a chest wall surgery. So wherever there is damage in the lymphatic architecture, there is no use of doing a sentinel lymph node biopsy, right? So whether if there is a previous breast surgery or breast or chest wall surgery, or a breast scarring as in like burns, or a patient who had underwent a radiotherapy. So in all the situations, there will be the damage in this lymphatic architecture. So there is no use of a sentinel lymph node biopsy. So, and also inflammatory breast cancer. Because in inflammatory breast cancer, it's a T4 disease, there is already a suspicious node present. Then why do a sentinel lymph node biopsy? Why do it? So basically what is SLNB is you just inject a dye into the peritumoral area. You can either inject dye or can you also use radioisotopes. So the dyes that are used are methylene blue, fluorescent, indocyanine green, and the radioisotopes are technetium-99, molybdenum labeled albumin, or the sulfur colloid or antimony. But the Bailey states that if you combine this fluorescent and methylene blue, the probability that the sentinel lymph nodes can be identified are more than 90% when you use this combination. So you basically are injecting this into the peritumoral area and it passes through the lymphatics and reaches the sentinel lymph node. If you have injected a dye, then it can be visually seen as a blue colored node, especially in a methylene blue dye, you can see it as a blue color node. If you have used a radioisotope, then it can be detected using the handheld gamma ray detection probe, where you can see the fluorescent node with blue light. So this is the fluorescent node, this green color fluorescent node with a blue light in the background. And this is this fluorescent sentinel lymph node seen using the infrared imaging with spy camera. And here, upon injecting the methylene blue, you can see this blue colored lymph nodes, sentinel lymph nodes. So coming back to the question, which of the following is the contraindication except for sentinel lymph node except? So yeah, scarring is a contraindication. Breast radiotherapy is a contraindication. Inflammatory breast cancer is again a contraindication. In T3, it's not a contraindication because if you don't have if you're suspicious of a sentinel lymph node, like lymph node which is not clinically present, then you definitely have to go for it, right? So T3 is not a contraindication. In a closure of laparotomy while closing all together, so closure of laparotomy while closing all together, which of the following layer is spared? So it's basically a mass closure. In this mass closure, which of the following is the layer is being spared? Skin, subcutaneous tissue, or peritoneum, or a muscle layer? So which of the following? Yes. See, the abdominal closure, all these things, this practice of this abdominal closure varies from hospital to hospital, but still there are lots of controversy existing. But most of these abdominal incisions, they aim at closing or approximating the rectus sheath or the linea alba in a continuous manner. Now let us discuss some comparisons that has been done, like layered closure versus mass closure. So yeah, so Bailey gives you that the abdominal wounds that can be closed either by closing all the layers of the abdomen, that is musculo-aponeurotic layers are being closed, which avoids skin. So yeah, it's again a direct statement from Bailey. So the abdominal wounds where you close all the layers of the abdomen, that is musculo-aponeurotic layers, but you avoid skin. And or else the layered closure is closing the individual layers of the rectus. When these both are not possible, you can the alternative to this both is that you can consider approximating only the anterior rectus sheath. So this is the image showing, like see, in the first image, these are all, this is the layered closing. So posterior rectus, anterior rectus, and then skin is separately closed. As in the second image, in the mass closure, musculo-aponeurotic layers are being closed all together and skin is closed separately. And we'll also see the other discussion, we'll also discuss the other comparisons, like which is superior, whether continuous sutures are superior or interrupted. Yeah, the simple continuous is being considered as the superior to the interrupted sutures. Why? Because in the continuous sutures, the pressure across the length of the wound is being equally distributed. Whereas the interrupted sutures, the pressure is varies. According to the individual suture, it varies, right? Whereas it is uniformly distributed throughout the wound length in the simple continuous sutures. And because of this, there is less chance of ischemia, and also this continuous sutures are quicker to perform. So because of this reason, simple continuous is considered superior to the interrupted sutures. And absorbable versus delayed absorbable versus non-absorbable sutures. So using all this, again, it's preferable to use delayed absorbable monofilament, which is PDS. But in a patient who had underwent multiple previous surgeries, it is wise to use a non-absorbable suture like nylon or polypropylene. And next comparison is between the big bite, big needle versus small bite, small needle. And again, yeah, what is accepted in these days is that the interval, the distance between the two suture and also the distance between the edge of the wound and the suture should be 5 mm. And it's preferably performed using a small sized needle, like 2O PDS is preferred over 1 PDS. And generally, what we all do is that we start the closure of the abdomen from both the ends, right? Right, from the superior and the inferior, and we meet in the middle. By doing this, like most of the sutures are taken under vision. So that is the advantage here. That's it. So this is that big bite, big needle, small bite, small needle. So see, this is the distance between the two bites, two sutures is also 5 mm, and the distance from the wound edge and where the bite is taken, that is also is 5 mm. So this is acceptable. Whereas in big bite, where the distance is both the distance interval between the sutures and also the distance between the edge and the suture is 1 centimeter. So this is not done these days. And also this is done using a big needle. So you can see, this is the place where you pierce the needle, and it is anticipated to cause some buttonhole defect, which might later on cause hernias. And let's see some alternatives to the skin sutures, like skin adhesive stripes and tissue glue or staples are all these are present. Considering coming to the suture removal, the facial sutures, these are removed at the 3 to 5 days, and neck sutures are removed at 5 to 7 days, and abdominal sutures you remove somewhere between 10 and 14 days. So these are the surgical stripes. This is used only in the clean incised wound. And here you can see the surgeon applying the tissue, like glue applying to being applied to the skin. Yeah, coming back to the question. So in a closure of the laparotomy, while closing all together, which of the following layer is spared? It is the skin. Okay. Next, first line management of the patient presented with hydrofluoric acid burn. So patient presented with hydrofluoric acid. What is the first acid burn? What is the first line management you do? Silver sulfur diazine cream, or calcium gluconate gel, or muffinide acetate cream, or Acticoat. This hydrofluoric acid, the burns caused by the hydrofluoric acid. So it's the most common cause of the acid burn. Hydrofluoric acid is the most common cause of the acid burn, though it is a weak acid, but its mechanism by which it causes the burns is that it chelates the calcium and magnesium. So by now you have known this mechanism. Now you can easily answer, right? What will be the, or what should be the initial management? You need to apply if the burns are very mild or like very superficial, then you need to treat with the local application of calcium gluconate gel. But if there are severe burns, especially involving the extremities, like both the limbs or both the upper or the lower limb, then you can go for this Beer's block that contains a calcium gluconate gel of 10%. So Beer's block is nothing but intravenous regional anesthesia. So you just inject the regional anesthesia and tie a tourniquet so that it prevents the drug getting disseminated systematically. Similarly, using Beer's block technique, you can inject this calcium gluconate gel wherever there are severe burns, especially involving the limbs. But if a patient is burnt with hydrofluoric acid of concentration more than 50%, even though it's a weak acid, if the concentration is more than 50%, then there are more chance that it would have chelated a lot of calcium ions, right? So there are chances of hypocalcemia and arrhythmias. So in such condition, you have to take the patient for acute early excision, followed by the excision, you can later on plan for an SSG. So you should remember that the important point here is that SSG can be done, but not in the initial stage. Only in a delayed stage, it can be done. So this is the overall management of this hydrofluoric acid burn. Initial is local application of calcium gluconate gel. If it is a severe burns, especially involving the extremities, you inject it via this Beer's block, which is an intravenous regional IVRA, intravenous regional anesthesia. Or if the patient has got succumbed to the burns with more than of concentrations more than 50%, take the patient for the acute early excision. Now, yeah, coming back to the question, so you know the answer. It's been calcium gluconate gel. Now, what about the other options? Silver sulfadiazine, muffinide acetate, Acticoat. Where are these agents used? It's basically used in the treatment of thermal burns. And each of this have some specific features like, see, coming to the silver sulfadiazine, it actually induces a sterile eschar. And also, in any burns patient who has been severe superficial or deep burns, there will be the cell-mediated reactions, antibody reactions happening, cell-mediated actions, immune suppression going on. So this silver sulfadiazine have some effect on this cell-mediated immune suppression. That is, it reduces the cell-mediated immune suppression, and also it induces the sterile eschar. And this muffinide acetate, again, it's applied locally, but upon local application, it causes severe pain, and it also gets absorbed into the system, like it can get systematically absorbed, and it's associated with metabolic acidosis. And what is this Acticoat? It's basically a nanocrystalline silver barrier that can be applied over the skin. So the name itself says it's a nanocrystals of silver. Size of the silver ions, the powder that is being used is 100 nanometers. So the nanocrystals of silver, and also upon application of the skin, it releases some silver ions. And this silver ions have this ability to kill lots of bacteria, a broad spectrum of bacteria. So they are effectively antimicrobial, especially against the broad spectrum. Okay. So these are the special characters of each and the other options. Next is an abscess involving deep incision is being found on CECT abdomen. Now, what is the type of surgical site infection? So, very easy question. Even if you don't know the classification, you'll be able to give the answer. So here, an abscess is being seen in the deep incision site in a radiological imaging. So what is this type of surgical site infection? So this clinical disease control, they have given us the classification of surgical site infection, where there is a superficial incisional SSI or deep incisional SSI and organ space SSI. First, what's this definition for surgical site infection? So the definition goes like, it is defined as any infection that occurs within 30 days after surgery if no implant is left in place. But if an implant is left in place, then any infection that occurs within 1 year. And also, all this infection that should be related to the operative procedure. That is, following an operative procedure, they should develop. So that is this completes the surgical site infection definition. So any infection that occurs within 30 days if no implant. within 1 year if implant is placed. And also all these infections must be appear to be related to the operative procedure. Now let's get into the classifications. So the first is superficial incisional SSI. Here it involves only the skin and subcutaneous tissue with one of the four following criteria. One of the four criteria, okay? The first one is there should be a pus discharge from superficial incision, and also you should be able to isolate organisms from the culture of either the fluid or tissue that you have retrieved from the superficial incision. And this is second criteria. The third one is you must have at least one of the signs of inflammation like cala, dola, ruba, a tumor, and a functional. One of these signs of inflammation must be present, and this incision can be opened by the surgeon, and its culture must be positive. Either it should be positive or it's like it has not been cultured. But if the culture turns out to be negative, then it doesn't meet this criteria. So coming to the final criteria, like it can be the diagnosis of the superficial incisional SSI, it can be made either by the surgeon or the attending physician, whoever comes to see the rounds. So basically, what is the superficial incision? It should involve only skin and subcutaneous tissue with one of the following criteria, like pus discharge from superficial skin, isolated organisms with one of the signs of inflammation, and diagnosed by surgeon or attending physician. Next is deep incisional surgical site infection, which involves deep soft tissues like either the facial or the muscle layers of incision. Again, with one of the four following criteria. The purulent discharge must be from the deep incision, but it doesn't mean that it should be in communication. It should be in communicating with it should not be communicating with the organ or any space component of the site, surgical site. So it's just the facial and muscular layers, not into any organ or space. The pus discharge from deep incision. And again, this deep incision, sometimes, most of the time, it will give away spontaneously, or it's either given away or opened by the surgeon. Again, the culture must be positive or not culture. The negative cultures will not meet this criteria. With one of the signs, like either the patient should have a fever of more than 30 degrees Celsius, a local pain, and tenderness. And the third criteria is that you can find either abscess or any other evidence of infection that has been involved in deep incision. That can be found out either during the rounds by direct examination or during the resurgery, or it can be either diagnosed by the imaging or the pathological, with the help of any pathology or imaging. So that is the third criteria. Fourth is, see, whenever you say a deep incisional surgical site infection, it means that the wound has both superficial and deep incision infection. So without the skin and it cannot jump directly into the facial layers, right? So there will be the involvement of both superficial and deep incision to make a diagnosis of DIS. And it can be diagnosed by both surgeon and the attending physician. So here in the question we had that the patient had an abscess that was seen in the deep incision, and that diagnosis was made in the CECT abdomen. So this criteria fits into it, right? So deep incision was involved, abscess was seen in the CECT abdomen, which is an imaging. So the answer is deep incisional SSI. Now let's also see this organ space surgical site infection. Here, it involves any part of the body excluding skin incision or skin subcutaneous or facial and all those muscles, whatever was involved in the superficial indication, except that any part of the body can be involved. And that can be manipulated or opened during the operative procedures. And also here, the patient must have one of the following criteria. Here, the pus discharge must be from either drain. Like after surgery, you place a drain, and then during the rounds, say in third or fourth post-operative day, you 10 or 7, somewhere around 6 to 7 the post-operative day, if you see some pus in the drain tube, but the incision site is absolutely normal, then it is called as organ or space. Yeah, the drain would have been communicating with either any organ or in the space. Say for perforation, you would have kept the drain in the hepatorenal pouch. So there can be pus coming from the drain, which means that the space, the hepatorenal pouch, that has been infected or that had not been cleaned enough during the surgery. The wash was not given enough during the surgery. Some reason might be there. So if there is a pus in the drain placed in the organ or space, then that is one criteria. And again, the pus, in that pus, you should be able to isolate the organism. And if the culture turns out to be negative, then yeah, it doesn't meet this criteria. Or you can have this abscess or other evidence of infection, which can be seen during rounds, direct examination, or resurgery, or pathological or imaging. Again, this diagnosis can be made by surgeon or the attending physician. So one of these 4 criteria, plus without involving skin, all those facial muscle, there should be some involvement in the organ or space. This satisfies the criteria of space or organ. So the answer for this question is, it's a deep incision, abscess seen in CECT, so it's a deep surgical site infection. Again, a simple anatomy-based question. Predominant blood supply to parathyroid gland is, superior thyroid, inferior thyroid, superior parathyroid, inferior parathyroid. So let's brush up some embryology here. So you have 4 parathyroid glands, which are placed in the 4 corners of the thyroid gland. And the superior parathyroid gland develops from the 4th pharyngeal pouch, and the inferior parathyroid develops from the 3rd pharyngeal pouch. Because it's from the 3rd pharyngeal pouch that the thymus also develops. So when the thymus, during embryological development, when the thymus descends into the mediastinum, it pulls along with it the 2 parathyroids. So that's why the inferior parathyroid develops from 3rd and the superior develops from the 4th. And all this happens at around 5th and 12th week of gestation. So grossly, it's described as Portland brick or the yellowish brown in color, and each gland weighs around 30 mg. And here, the blood supply of both is from the inferior thyroid artery. So it's a very simple question. So it's from the inferior thyroid artery. Yes. Next question. Which of the following is not included in WHO surgical list? World Health Organization surgical safety checklist. Which of the following is not included? Oxygen saturation, operative site marking, risk of blood loss, or risk of difficult airway. So the question is simple, but the options are tricky, right? Some of you might find it very difficult to put your finger on any of these options. But it's very simple. It's quite simple. Coming to this is the tabular column. There's surgical safety checklist given by the World Health Organization, and you have certain columns like sign in, time out, and sign out, which has been done before induction, before skin incision, and before the patient leaves the operating room. So let's get into the elements of the surgical safety list one by one. So in sign in, it's done before induction. It should be checked at least with the nurse and the anesthesia team members, where you where the patient's identity and surgical site and site marking, everything has been confirmed and done. You should check whether the pulse oximeter is present on the patient and is functioning or not. That's it. It's not asking for the oxygen saturation directly. It just asks you whether you have put the pulse oximeter on the patient. That's it. And then this patient's allergy history, like any specific concerns related to allergy history is present or not. And difficult airway or risk of aspiration is present. And what is the anticipated blood loss or risk of blood loss? So that is all it's been given in the induction, before induction state, which is a sign-in phase. So in the option, you have operative site marking. Yes, it is given. It is included in this WHO surgical checklist. And see here is the pulse oximeter on the patient and is functioning. That's all. See. And next is regarding the risk of difficult airway, regarding the risk of blood loss. So all these are present. Do you see anywhere it's asking for oxygen saturation? So what you understand out of this is something different from what is actually given in it. So facts are facts. Facts cannot be altered. Got it. And next is coming to the timeout session, which is done before the skin incision, and it's done with the entire team members of nurse, surgeons, anesthetist, and whoever has been involved in this patient care. All of us get introduced by the name and their role, and again confirm the patient's identity, site, and the procedure. And each team have to review their anticipated critical teams, like events, like if the surgeon, like if he's planning to take any non-routine steps, then he might express his concern about that. And also about the duration he might take to complete the surgery, and what could be the blood loss. An anesthetist regarding if the patient is having any difficult airway or loosening of tooth, all those things have to be mentioned. Or if the patient is having fused or fixed spine, then giving a spinal or epidural might be difficult. So all those concerns have to be expressed by them. And nurses, again, if a surgeon is planning to take a non-routine step, which might be in which he might be needing some of the different equipment, so then the nurse must check with the surgeon that all those such equipments are available or not, and also check with the sterility and all other stuffs like whether prophylactic antibiotics are given or not, and essentially imaging are being displayed in the operating room. Next is sign out. So this has been done before the patient leaves the operating room. So here the nurse checks whether the done and the documented procedures are same. And the nurse have to check the instrument and pad count. And if at all there is any specimen that have to be labeled properly. If there was any issues with equipment, then that also have to be addressed. And before the patient leaves the ward, any concerns regarding the recovery and care of the patient must be expressed by this or given by the surgeon or anesthetist or nurse. So yes, coming to this, back to the question. See, this is a very simple question, but you have to have this clarity. That is the level you have to answer such questions. So yes, the options are tricky. So I would like to give the answer as oxygen saturation. There is nothing in the list that is asking for your oxygen saturation. So I would also like to ask you one thing, like, do you know who actually formulated this WHO surgical checklist? Nowhere in this any book or whatever book you have referred, nowhere it's any particular surgeon name is sorry, particular doctor's name or some who a person's name is not mentioned, right? But you all should take really pride in telling or knowing that this who surgical safety checklist was given by a surgeon, Atul Gawande. He's not only a surgeon, actually he's also an author. He's a writer too. He's a renowned writer too. Like he has given two famous books like Being Mortal and Checklist Manifesto, all these things. So once when questioned upon to like from where did he get this as inspiration to form a checklist for this surgery before doing a surgery, he gives the like one of his speech he told that he got his inspiration from a cowboy. Cowboy? Which like how like that? Like he says that once he got inspired by that one cowboy who was managing a thousands of herds like cattles which were placed in different places. He was herding a thousands of cattle that was being placed at different places. And out of curiosity, he asked out, how do you manage to herd such a huge number of cattle? He simply said that we have some protocols and checklist, and my work is just to supervise all this, blah, blah, blah. He was deeply moved by it. So the person who's dealing with the animals is having a checklist and protocol. Come on, we are dealing with lives, healthcare professionals. We are dealing with life. Then why not we have some safety checklist before we do surgery? So just like this, he got inspiration from this cowboy and he formulated it and who took it over from him, for which he didn't even claim any reward or any kind of recognition. So that's a simple background history behind this whose surgical safety checklist. Yeah, moving on to the next question. So how much fasting period required for the cow milk? We were discussing about the cattle, and next question is about the cows. Come on. So this is also a straightforward question from the Sabiston. Yeah, it gives you the recommendation. So fasting period, what is the minimum fasting period between the food, like between you take before you take the patient for surgery? In this recommendation, yeah, it gives it says that for clear liquids, especially like for carbohydrate liquids, the minimum fasting period should be 2 hours, and for the breast milk, it is 4 hours. And for the infant formula, non-human milk, which is close to this cow's milk, right? And also for light meal. All these three should have a minimum fasting period of 6 hours. And the meals which are rich in fat, like fried food and meat, so they take very like more time to get digested, right? So they must be given a minimum fasting period of 8 hours. So it's a direct question. 6 hours. How much fasting period required for cow milk before surgery? 6 hours. Coming to a calculation-based question, quite interesting question this is. What is quite interesting? You know, we all have, like, you all know the formula. You just apply the formula, you get the answer. So simple. What is quite interesting in this? You might be thinking, right? Now let's get into it. Calculate the sodium deficit for the patient of 50 kg male with sodium of 123 milliequivalents per liter. So I'll give you the formula also. So there is a formula in Sabiston. So sorry guys, I have mentioned Bailey as 21st edition. It's Sabiston 21st and Bailey 28th edition. So wherever you say Bailey, it's 28th edition. Okay. Now this is the formula where we calculate the sodium deficit. So this is sodium goal minus like whatever you target to treat. What is this? You have to set the target level of sodium level and then that minus the plasma level of the patient's sodium level into total body weight. And the total body weight is weight into 60%. That is 60% of body's weight is total body weight. So we have the patient's plasma level is 123 and patient's weight is 50 kg. So given this, you also know that the normal sodium level is 135 to 145. So just apply and see what is the value you get. 135, you can take the low normal. So 135 to minus 123 is 12. And what is 60% of 50? It's 30, isn't it? So 12 into 30 12 into 30, it comes around 360, right? See, you don't get the answer. 360 is nowhere near to any of these options. Interesting. So now, see, the patient is in hyponatremia. The patient definitely is in hyponatremia. But this is a very minimal level of hyponatremia. For 123 and all, the patients definitely will not be having any symptoms. It is individualized. Okay. So this hyponatremia, if a patient is having any electrolyte abnormalities, all these patients they get to treat under the critical care. And when it comes to critical care, it is always stopped by the anesthetist, and they have this reference, a Bible for their reference of critical care is Oxford Disc Reference in Critical Care. And here, this states that in this book states that you should never ever rapidly correct this sodium. So rapid correction is unnecessary and it should never exceed 0.5 millimoles per liter. And also it says that if at all a patient is having a symptomatic hyponatremia, then at that circumstances, you can increase the rate mildly to 1 to 2 millimoles. So otherwise 0.5, but if symptomatic, it is 1 to 2 millimoles per liter. So even in the classification of hyponatremia, the values are taken from 120. So there is something called mild, moderate, and severe hyponatremia. Even the patient is graded as mild hyponatremia only when the plasma sodium levels are less than 120. But our patient's plasma value are 123. So it's somewhere in the normal and it's somewhere between the normal and mild hyponatremia, right? So the third point is a very most important point that will be giving you some clue how to calculate this equation or calculate this deficit for our patient. So yes, the targeted rate of correction should not exceed 10 millimoles per liter on any day of treatment. So on any day, you should never exceed 10 millimoles per liter. So our patient's plasma level is 123. You should not exceed 10 millimoles. So if you keep it as 133, again, if you calculate 133 minus 123 is 10, 10 into 30 is 300. Again, it's nowhere near to any of these options, right? So you can round it off to either 135 or 130. See, 135, if you round it to 135, it again becomes 12. So you're exceeding this 10 millimoles. So you just round it to 130. So now the target is set to 130 and weight, you know. Now apply it in the formula. 30 minus 123 and there is 30, which is total body weight is 30. And you get it as 20 milliequivalents. So sodium deficit is, you have got the exact answer. See, the examiners are not fooled to give you options like this. There should be definitely a correct answer, one among this option, isn't it? And also, they simply don't want us to play with the numericals. They know that you know the formula and the values are also been given. The main ideology behind asking this question is that you should know certain concepts. Okay, so always don't think that's like most of the time, right from your UG period or PG entrance exam, all these entrance exams, we always had this difficulty at arriving exact numerical values, isn't it? Especially, it's all because of the lack of concept. At those times, we had actually lacked the concept behind the question. Now that you have known the concept, now you arrived at the exact answer. So now next, moving to the next question. Filigree burns, come on, it's very easy question. Yes, it's when the lightning burns. It's caused by the lightning burns, and it's also called as arborescent or the filigree burns, and it resembles the lichen bug flowers. See, this is basically a filigree burns. So whatever I'm going to describe it now, every single word is very important. See, they are superficial, thin, irregular tortuous erythematous. They are superficial, thin, irregular, erythematous, and tortuous. So all this is the exact description of a filigree burn. And it resembles the branches of a tree and usually found on the shoulders and back and flanks. Okay, but you should know that the lightning burn does not always cause filigree burns. And before that, what is the reason? Like, what is the cause for this filigree burn? Is that it might be because of the tissues getting stained by the hemoglobin that got released by the RBC lysis, or it can be because of the rupture of small blood vessels at several places, or because of the minute deposition of copper in the dermis. And all this indicate the path that has been taken by the electric current through the patient. And if the patient survives for 1 or 2 days, like if the patient survives, this filigree burns will disappear in 1 or 2 days because it's very thin and superficial, right? So if the patient survives, you can see that this filigree burns disappearing. And yeah, there are other types of burns that are being caused by these lightning burns, and they are yeah, this takes its reference from Narayana Reddy. It's a forensic medicine book. Okay, yeah. So the other burns that are caused by this filigree, like lightning burns, are the linear burns. They are just 3 to 30 centimeter length. They are seen under the moist creases and folds of skin. And surface burns, actually, they are the true burns. When you are in contact with any metallic objects or any surface, and that time you have got this lightning burns, and you can have this burns beneath the metallic objects. When you are in contact with metallic objects, that surface get burnt because of that lightning. So these are actually the true burns. And if at all the death had happened on spot in a lightning burn, then that is always because of the accident. Because upon lightning stroke, this lightning stroke will throw the patient or the individual to a long distance where he might get hit by a tree trunk or lamp post. So because of this accident, death always ensues. If there is a death, it's always due to accident. Okay. Yeah. So filigree burns, it's because of the lightning burn. Washier flap. So it's a plastic surgery based question. So washier flap is used for nasal reconstruction, oral reconstruction, eye injury, neck dissection. Yes. So Grab's Encyclopedia of Flaps, which is like Nelligan is the Bible of plastic surgery. Grab's is another standard book for flaps, reading about flaps. Fourth edition, volume 1 states that this fascia flap is nothing but it's a retroauricular temporal flap. So it's a retroauricular temporal flap, and it was first described or demonstrated by the surgeon Vascio, hence the name Vascio flap, Dr. Vascio. So it's based on the pedicles of superficial temporal and the retroauricular arteries. And it's used for the nasal reconstruction, especially the alar reconstruction. So let's get into the details of it. So you can see here, right? This always flaps, raising a flap or complex thing about flap is marking the exact points in rhomboid flap, in bipedicled or bilobed. All these things, first, the marking is very important. Listen, you take a marker and you just mark it. It's very important, the marking. Similarly, for washier flap, we have to make this rhomboid initially. So you can see the points A, B, C, D, right? So how are these points arrived at? It's very simple. This point A is marked just in front of the anterior helix of the ear. A is marked in front of the anterior helix of the ear. That's it. That is point A. And next, you imagine a vertical line through this point A. And this is an imaginary vertical line. And point C is marked 10 to 15 degrees behind this imaginary vertical line that is passing through this point A. So point A is in front of anterior helix. And imagine a vertical line passing through this point A. And C is marked 10 to 15 degrees behind this vertical line. Okay. You got this point C. Now, what is this? What is the length of AC? How will you decide the length of this AC line? That is that is again very simple. See, it's just half of the length, half of the distance between this point A, and say if there is an ALR defect here, you're planning to reconstruct the ALR. So it's half of the distance between this point A and the defect. So that is the length of AC line, AC. Got it? Now coming to this B point. B point again, it's marked in such a way that the angle formed by CAB is 60 degrees. So basically a equilateral triangle. So CAB, angle formed by CAB is 60 degrees. In such a way, the point B is marked. Or roughly, you can also take like this AB line can be marked along the anterior hairline. But in situations where the patient is a bald patient or is having some anterior the receding hairlines, in such cases, you cannot take it roughly as the anterior hairline. So in such cases, it's wiser to go with this, like the angle formed by CAB is 60 degrees. So we have got these 3 points now. Now, how will you mark this point D? That is also very simple. So now you see there is a triangle over here. ABC is a triangle and BDC is a triangle. So D is marked in such a way that both these triangles are equilateral. Symmetrical triangles are formed. So CAB is forming one triangle and BDC is forming one triangle. So D is marked in such a way that approximately both these triangles are symmetrical. So you got these four markings. So A is in front of the anterior helix. Imagine a vertical line. So 10 to 15 degree behind is point C, and length of face C is halfway between point A and the defect. And AB, B is marked in such a way that CAB, that is CAB is 60 degree, and D is marked in such a way that this both triangles, CAB triangle and BDC triangle, are symmetrical. And then an arch is made, and you reach out and complete the arch, go behind the ear and make a cut. All these are done roughly. And this, among all these points, this AB line is very important because it is through this line you actually twist the whole of the flap and bring it to the anterior. So from the posterior, you just bring the whole flap to the anterior through this AB line. So it's very important to, the AB is most important in this among all these points. And how is this flap created? See, after raising the flap and also twisting and bringing it anteriorly, you just fold the flap in such a way that the raw area of the flap face each other. So the raw areas get inward. Fold the flap in such a way that the raw areas fold inward, that is face each other, and the point is brought to the tip of the nose to reconstruct. Got it? So this is this lady. This is the picture, same picture given in the Grab's Encyclopedia of Flaps. So this lady had underwent hemangioma, resection for hemangioma in her infant period, and was followed by radiotherapy that ultimately destroyed her ALR. So she was planned for this vascular flap. See, the markings are being done. And yeah, the flap has been raised through this AB line. It's been brought forward anteriorly, and this is how the tip is brought, and the ALR has been reconstructed. So this is the pic which was taken after surgery, 2 weeks after surgery. And see, post-operative photo of her. This is the pic which was taken 9 months later. So I'll give you a more colorful picture where, see, this is the ALR defect. This is the marking is being done, incisions made, flap raised. And see this, through this AB line, the flap is brought to the anterior and it's folded inward in such a way that the raw areas face each other, and the tip is brought to the nasal tip, and it's been reconstructed. So yeah, coming back to the question, quite interesting, right? So vascular flap, it's used for the nasal reconstruction, especially the ALR reconstruction, and it's based on the superficial temporal and retroauricular pedicles. Okay? Yes. Next, 51-year-old female post-mastectomy on day, 51-year-old woman post-mastectomy on day 10 presented with a large seroma at operative site. Now, what is the management? So basically, there is a large seroma after MRM, and she presented on day 10. What is the management? Whether it's aspiration or wait and watch or excision of the involved part, or you go for radiotherapy. What is a seroma? It's nothing but a fluid filled with fat, serum, and lymph. And when will you have this development of seroma? Wherever you create a dead space or wherever there is an interruption of lymphatic. So examples are breast surgery, axillary dissection, or hernia surgeries, right? So now that you know this cause, know how it is formed, you try to prevent it, right? So how will you prevent it? You just excise the excess skin if it is present, or you can also use fibrin sealants or quilting sutures or the medical talc. All of this can be used. And now that you have tried all the preventive measures, but again, the patient are presented with seroma. But how will you manage it? If it is asymptomatic, no problems. It will resolve on its own. But if it is symptomatic, then you need to aspirate it under strict aseptic precaution and apply a pressure bandage. But you can thrice of aspiration, like aspiration can be tried thrice. But even after that, if there is a refractory seroma, then definitely that patient have to be considered for surgical drainage. Okay. Now, in this question, so you can see that there is a large seroma. Obviously, there is a large seroma. So in postoperative day 10, she's coming with a large seroma. You have to aspirate it, right? She will be symptomatic and you need to aspirate. You cannot wait and watch. If it is asymptomatic only, you can wait and watch because it can resolve spontaneously. But they have mentioned the only glitch here is this large seroma. So here the answer should be aspiration. And what about this excision of involved part? The excision of involved part is not something you do on the postoperative day 10. It's done on the day of surgery on the operative table itself. Like if there is an excess skin, you just excise. And this radiotherapy is out of the equation. Why you use radiotherapy for seroma? Yeah. Next is a patient with Graves' disease presented with spasm of the upper eyelid, revealing the sclera above the corneals, revealing the sclera above the corneoscleral lumbus. Now, what is this sign? Simple questions. So, von Graffi sign, Darlimple sign, Joffrey's sign, or Stellwax sign. Spasm of upper eyelid exposing the upper limbus. So, in Graves' disease, most like 50% of the patients will be having ophthalmopathy, and 1 or 2% will have dermopathy, and that is because of the deposition of gas that causes the thickened skin in the pretibial. Like it causes pretibial myxedema, and also over the dorsum of foot there will be thickened skin. But this is the reason for dermopathy. What is the reason for this ophthalmopathy? What is Graves' disease? It is an autoimmune disease with antibodies against TSH receptor. Now, what is the reason for this ophthalmopathy is that some of the orbital fibroblasts and also muscles in the eyes, like orbital muscles, they share this common antigen TSHR. So obviously the antibodies will start attacking them also, eliciting inflammation and release of cytokines from all those sensitized killer cells. So there will be inflammation, fibrosis, scarring happening, and there will be all of which will deposit in the retroorbital region, pushing the eyeball forward, causing exophthalmos. And that is the reason for all the rest of the other signs, eye signs. So this is the pretibial myxedema with deposition of glycosaminoglycans. And eye symptoms, yeah, it includes lid lag. So whenever you ask the patient to look down, the upper eyelid have to follow the eyeball. But because of this lid lag or the spasm of the muscle, it's not just there will be lag, right? Lag of the upper lid. Like the upper lid will not follow the eyeball. So that is von Graffi sign. And there will be spasm of the upper eyelid, which reveals the sclera above the corneoscleral limbus. So this sign is Darlimple sign. And there will be a prominent staring look. And that is because of this excess catecholamines. Because of the hyperthyroidism that causes excess catecholamine release, there will be a prominent stare also. And in a true infiltrative eye disease, so it is an infiltrative disease, there is infiltration, right? Like in a infiltration by all those inflammatory cells. So in a true inflammatory eye disease, there will be periorbital edema, conjunctival swelling, and congestion. That is chemosis. And there will be proptosis, and also sometimes there can be involvement of the orbital muscle, ocular muscles, like especially this inferior and medial rectus muscles. As a result of which, there will be limitation in the upward and lateral gaze. That is, inferior rectus muscle is being involved, so that causes spasm. So the upward gaze is limited. Similarly, when the medial rectus muscle is infiltrated, then it limits the gaze in the lateral. So the lateral gaze, laterally, the gaze is being limited. So because of the involvement of the inferior and medial rectus, there is limitation in the superior and the lateral gaze. Got it? And also because of this exophthalmos and also lid lag, the patient cannot close the eyes completely. That leads to exposure keratosis and keratosis and keratitis, and ultimately leading to blindness. And also the blindness can also be due to direct infiltration of the optic nerve also. So it can be a direct infiltration that can cause blindness, and also with the exposure keratosis that can cause blindness. Okay. So this is that true infiltrative eye disease, which causes this periorbital edema. You can see this congestion over here, conjunctival swelling. So this is the true infiltrative eye disease. This is the picture given in Schwartz, page number 1636. Yeah. Coming back to the question, with the spasm of the eyelid, upper eyelid, exposing the upper limbus, what is the sign? It's Darlimple sign. Now, what is von Graffi sign? I already discussed. So, lid lag, that is the upper eyelid not following the eyeball. And yeah, Joffrey's sign. Joffrey's sign, see, basically, normally, our field of vision in the superior aspect is restricted because of the presence of the supraorbital ridge. It's normally reduced. So whenever you ask for everyone, normally when we look up, there will be wrinkles appearing because of the strain that is made in the frontal muscles. But in case of exophthalmos, where there is protrusion of the eyeball, the patient doesn't have any difficulty in looking up, so he doesn't have to strain his frontal muscles. So there is absence of wrinkles, which is Joffrey's sign. And Stellwax sign, it's because of the infrequent blinking. That will also give you a staring look. Now, next is which of the following is the tumor suppressor gene of thyroid malignancy? So, tumor suppressor gene of thyroid malignancy. Again is a simple question, but the options are tricky. So all these genes are involved in the thyroid malignancy. But which of the following is a tumor suppressor gene? So for which you need to know some molecular mechanisms, whether it's a red proton gene or P10 or RAS or TRK. So basically, there are two molecular mechanisms which governs the thyroid malignancy, and they are MAPK pathway, that is mitogen activated protein kinase signaling pathway, or phosphatidylinositol 3 kinase AKT pathway, that is protein kinase B pathway. So these two are the molecular mechanisms basically involved or governing the thyroid malignancies. So normally thyroid gland itself acts based on this molecular mechanism. If there is any alteration happening here, will lead to a tumor like tumor growth. Now let's see this first pathway, MAPK pathway. So whenever there is an increased demand for the thyroid hormones, or whenever there is a stress, so all these are physiological and environmental signals. They actually come and activate this NAP3 case. So upon activation, they release certain proteins, NAP2K proteins, and that act on the second tier of genes. And ultimately, they'll end up producing a transcription factor that go and alter the gene expression, leading to this differentiation, proliferation. And you know that a tumor cell will always find its way to escape the apoptosis. So by differentiation and proliferation, and also by escaping apoptosis, it promotes survival of tumor growth survival. So that's the cell survival, tumor survival is augmented, isn't it? So this is, if it takes place in a controlled manner, that is normal. But if it is an uncontrolled, there is no checkpoint, then there is only stimulation happening throughout the process, right? There is no suppression anywhere happening. So all the signals, it causes the activation of MAP3K that releases some proteins and which acts on second tier of genes and ultimately leading to a transcription factor that acts or alters the gene expression, resulting in the differentiation, proliferation, apoptosis, and escaping out apoptosis and survival. Now, what are the genes that actually use this MAPK pathway is that BRAF genes, RET, and RAS, and this neurotrophic tropomyosin receptor kinase genes. So all these genes use this MAPK pathways. So we had all this in the option, right? So next, coming to this PI3 phosphatidylinositol 3 kinase or AKT protein kinase B pathway. See, again here, so these are the representatives of this physiological and environmental stress, like insulin-like growth factors. So all this gets stimulated and they come and phosphorylate the phosphatidylinositol 3 kinase. So upon phosphorylation, it gets activated and it stimulates the protein kinase B. So thus this AKT pathway is stimulated that promotes the tumor cell survival. Again, there is no suppression here. There is only stimulation. But you can see something here, right? P10 gene. This normally reverses this stimulation process. That is, it inhibits the phosphatidylinositol 3 kinase. So that is, it dephosphorylates this PI3K. So upon dephosphorylation, there is no stimulation happening. Hence, there is no promotion of this tumor cell survival. Hence, from the image or this pathway, it's very crystal clear that among the options, P10 is the only gene which is a tumor suppressor for the thyroid malignancy. Rest all the others use this MAP3K pathway. All this acts, there is only stimulation happening here. Stimulation causes differentiation. Stimulation causes proliferation. And all this tumor cell have their own ways of escaping apoptosis, and ultimately the tumor survival is promoted. Whereas in P10, it suppresses the tumor. So this is the only tumor suppressor gene for thyroid malignancy. Got it? Next, again, a plastic surgery related question. In a radial artery forearm flap, how the vascular supply penetrate the fascia? Yes. So there is a classification called as Nahay-Mathis classification of fasciocutaneous flaps. So before discussing this tabular column, I'll show you the picture. So this is the mother vessel where you can see one branch directly reaching the, like piercing the fascia to reach the skin and supply the skin. So that is called as direct cutaneous perforator. This is the other branch which perforates through the muscle to reach the, and also through the muscle, it pierces the fascia and reach the skin to supply it. So that's called as muscle perforator. And between these two muscles, you have a septum, which is separating between the two compartments. And there is another branch from this vessel piercing through the septum to reach the skin. So this is called as subcutaneous perforator. Now coming back to this tabular column of classification, Nahai-Mathis classification of faciocutaneous flaps. So type A flap is direct cutaneous flap, where we saw that the vessel reaching directly the skin. So example for this is temporoparietal facial flap. Okay. And type B is septocutaneous, like you saw that a vessel piercing the septum, isn't it? So that is type B. So type B is a septocutaneous vessel that penetrates the fascia. An example for this is radial artery forearm flap. And type C is musculocutaneous. You saw a branch that is piercing the muscle to reach the skin. An example that is called as muscle perforator. So there is a musculocutaneous vessel which penetrates the fascia, and that is type C. So example for this is tram flap, which is the transverse rectus abdominis myocutaneous flap that is being used in breast reconstruction, isn't it? Yeah. So this is Nahai-Mathis classification of faciocutaneous flap, and this is the pic we already discussed. So we have a picture showing radial artery. So this is the septum that contains the radial artery and also some concomitant veins that pierces or runs through the septum and reach the skin to supply this part of the skin. Got it? So radial artery forearm flap is a septocutaneous vessel. Very simple. Basically, you have to know this classification. That's it. Again, one more classification from plastic surgery. Yeah, a vascular supply of gastrocnemius flap has one vascular pedicle. And what is the type of muscular flap classified by Mathis-Nahai? Whether it's type 1. So everything is being given in the question. Vascular supply of gastrocnemius is one vascular pedicle. And what is the type? The classification name is also given. That is muscular flap classified by Mathis-Nahai. So Nahai-Mathis is for faciocutaneous and Mathis-Nahai for the muscular flap. So yeah, just need to know what is what, type 1, 2, 3, 4. So first I'll describe all this. So it's Bailey 28th edition. In 690, it's been given. Muscle flaps class. First I'll describe the types, and then I'll show you the picture. Okay. So it's type 1. So in type 1 flap, the flap will be having a single vascular pedicle. An example for this is tensa fasciolata and gastrocnemius. And in type 2, you have one dominant pedicle with one or more minor pedicles. And examples for this is sternocleidomastoid, trapezius, gracilis, biceps femoris. And see, the important point to note here is this flap cannot survive only with the minor pedicle. It requires or it necessitates this dominant pedicle also for its survival. So examples are gracilis, biceps femoris, and sternocleidomastoid. Type 3 is trapezius and soleus. And type 3 is dual dominant pedicles. So see, type 1, there is one vascular pedicle, and type 2, one dominant and one or more minor, and 3, you have two dominant pedicles. And examples are gluteus maximus, pectoralis minor, rectus abdominis, serratus, and temporalis. Okay. Type 4 is you have segmental pedicles, and examples I'll show you in the picture. Okay, don't worry. Examples of sartorius, all those things. And type 5 is you have a dominant pedicle with several minor pedicles, but unlike type 2, here the flap can survive with the minor pedicles alone. Got it? Now let's see the diagram. This is type 1, where you have a single vascular pedicle supplying the whole flap. So example is tensa fasciolata and also gastrocnemius. This is an example for type 1 where you have single vascular pedicle. And here in type 2, we have one dominant. Most of the flap, the larger part of the flap is being supplied by this dominant pedicle. And you have one or two minor pedicles. So a minority of this flap is supplied by this minor pedicles. See this type 2 flap, this whole flap cannot survive only with this minor pedicle. It requires this dominant pedicle also for its survival. An example is gracilis or sternocleidomastoid, all those things. Trapezius, soleus. And type 3, see here you have two dominant pedicles, 1 and 2. Two dominant pedicles, example gluteus maximus. And this is this type 4, which have segmental pedicles. Every part or segment of the muscle is being supplied by a segmental artery. So that's what's called a segmental pedicle. Example is sartorius or flexor hallucis longus, tibialis anterior. All these are examples for type 4. And in type 5, yes, this is one dominant pedicle with several minor pedicles. So unlike type 2, this flap can survive with this minor pedicles alone. It does not always necessitate or mandatorily require this presence of a dominant pedicle. So that is the difference between type 2 and 4. Got it? So example, latissimus dorsi, all these are examples. Okay. Now this is Nahai-Mathis classification of muscle flap. Now coming back to the question. So vascular supply of gastrocnemius is one vascular pedicle. So single vascular pedicle. What is the type? Simple, right? It's type 1. Matthews-Nahai muscular flap classification. Again, hit another calculation-based question. A 31-year-old female with 57 kg came with 21% of flame burns. Now, how much will you give, fluid will you give in this patient for resuscitation? Simple, right? You just apply the Parkland formula and get the answer. But the basic ideology, the main ideology behind the examiner asking this question is that whether to check, are you updated with this latest ATLS edition, 10th edition, which gives you this modified Parkland formula. This modified Parkland formula gives formula is that it states that the formula is it's not 4. So conventional Parkland formula was 4 into total body surface into weight in kg, but modified Parkland formula it is 2 into percentage of body surface burnt and weight in kg. So the volume what you get is in ml. So it's 2 into 21% and weight was 57. So again, you get an answer somewhere around 2394, 2300 approximately. You got the answer right. 2300 ml. So again, you got an answer that is present in an option, right? So always in a calculation-based question, you just try to recall some concepts behind it before blindly applying the formula and the values in the formula. Okay, very simple. Modified Parkland formula is 2 into body surface area into weight. Okay. Next, what is the first line management in the infant with Peary-Robin sequence? For which you need to know the Peary-Robin sequence. So let's go through the options. Whether you'll give bag and mask ventilation or a prone position, oral airway oxygenation or a nasal airway oxygenation. So what is the first line management in the infant with Peary-Robin? So yeah, it takes its reference from Nelligan, her plastic surgery Bible of plastic surgery. So here, the Peary-Robin have described the triad of micrognathia, that is the underdeveloped lower jaw, and glossoptosis is protrusion of the tongue. Protrusion of the tongue. Okay. The protrusion of tongue forward will not cause any, like anteriorly will not cause any pathology, nothing. But protrusion of the tongue, which means it's been backwardly placed, and that poses significant threat to the respiration, and thereby it leads to respiratory distress. And also there will be the child will be having some feeding difficulty also because of this posteriorly placed tongue. So the triad is basically micrognathia, which is underdeveloped jaw, glossoptosis is protrusion of tongue, and respiratory distress. But in 60 to 90% of these Peary-Robin patients, they might or they can have cleft palate also. And this cleft palate is usually isolated to velum. Velum is nothing but soft palate. And the shape of the cleft palate that is present that is involving the velum is, it can be either V-shaped or more typically it is U-shaped. Okay. So let's see this picture. Here, this is glossoptosis, which is protrusion of the tongue, that is backward position tongue, micrognathia, where you have underdeveloped jaw, lower jaw especially, and airway obstruction. So this is the triad. The cause for this Peary-Robin is actually not understood. It can be because of any isolated mutation, or it can be a syndromic also. And the most common syndrome that has been associated with this Peary-Robin is Stickler syndrome. So, what is the Stickler syndrome? What are the components of the Stickler syndrome? It's very simple. The name itself says that the patient or the child will have to use stick at a very early age. So that's why it's called a Stickler syndrome, probably. Why? Yeah, the child can have early degeneration of the joints, for which he might have to use the stick, or he can have the child can have these ocular defects like myopia, cataract, or the retinal detachment, again, which necessitates the usage of stick. So, and also other anomalies like mid-facies anomaly like cleft palate, and the auditory like problems like hearing loss. And hearing loss is mostly, yeah, it is like both sensory neural and the conductive hearing loss. All this. So these are the components of the Stickler syndrome. It's the most common syndrome associated with Peary-Robin sequence. And see, this infants with Peary-Robin, they can also have other anomalies, particularly in the cardiac and renal problems. And as I already mentioned, the babies can have problem with respiration and feeding because of this posterior displacement of the tongue. So you have known all the components of this Peary-Robins. Now, coming to the management. What is the initial management? Initial management consists of Because of this protrusion, the major problem posed is by the placement of the tongue backward. So the initial management will be placing the child in a prone position. And the other initial management includes using a gastric lavage feeding tube that can be used to push the tongue forward or a nasal airway. All these can be used. If all these conservative measures fail, then you can go for the surgical management where you tie the tongue to the lip. So that is called a tongue lip adhesion. It's an alternative to a tracheostomy. Okay. But sometimes the child can have this catch-up growth. The mandible can catch up with the growth as the child grows. But if so, you can at least wait for around 1 year. But if there is no such growth happening, then after 1 year, you have this option of mandibular distraction osteogenesis, where you place put some plates into the mandible and give a distraction of a few mm's every day. I'll show you the picture for this. And next is palatoplasty. So 60 to 90% of the patients will be having cleft palate involving the soft palate, right? Involving the velum, right? So in such patients, the palatoplasty can be it can be considered, and it must be carefully timed with the growth of the child, especially with the growth of the mandible. But if suppose the management is focused only on the airway means, then you need to perform a bronchoscopy to rule out any subglottic problems. Because the proglottic problem is this. What is the problem? It's very obvious because of this backward position tongue. All this poses threat to the respiration, right? But if you're planning to focus your management only in airway, then do a bronchoscopy. You rule out any subglottic problem are present like laryngomalacia, because even after doing all this tongue lip adhesion or putting the prone position, if still the baby is having difficulty in respiration, then there can be chance of laryngomalacia. But if that is, which is like collapse of this larynx, right? But in such situations, it mandates it mandates us to do a tracheostomy, right? And this is that mandibular distraction osteogenesis, where you put the plates into the mandible and see a cut is made in the mandible and the plates are put, and every day around 1 mm of distraction is being given. So that stimulates the epiphysis of the mandibles. The mandible catches up the growth. So that will be artificially or inducing or stimulating the growth of the mandible if it doesn't catch up with a child's growth. You can just, maximum you can wait for 1 year. Otherwise, you can put this mandibular distraction osteogenesis. And especially for, you cannot wait for all the patients. So if the patient is associated with syndromes, then such babies, they have less tendency to, for the such babies mandible have less tendency to grow. So only those who are not associated with syndromes, that is non-syndromic cases, you can just wait for the mandible to grow. You can anticipate it. And if the mandible attains a reasonable size in first year, then palate repair, if present, can be addressed safely before 1 year of age. So coming back to the question, what is the first line management? You got the answer right. Prone position. If prone is not in the option, then you can go for a nasal airway oxygen. Oral airway, it doesn't make sense, right? Bag and mask, if there is backward position, then how bag and mask ventilation will help you? It won't, right? So that's it. If nothing is given, then you should check, you can go for surgical options like tongue tie, or tracheostomy, mandible osteogenesis, distraction, or palatoplasty as such. Those are the other options that can be considered if it is given. Yes, coming to this last before question. So totally you have 25 questions. So we have reached the 24th question. Which of the following is true about FEV1 criteria for lobectomy? So basically for this lung cancer patients, where you plan for a lung resection, either for the lobectomy or pneumectomy. So lobectomy is resection of the lobe, and pneumectomy is removal of entire lung. There are certain criteria based on which you can decide on the procedure. What procedure to be decided on which patients. So all these have certain criteria. So right lung, it has 3 lobes, like right upper lobe, right middle, and right lower. And left is left upper and left lower lobe. This for the others who are quite not interested in CTS, I'll give you this direct answer. It's a direct statement from the Schwartz 11th edition in 692 and 94 pages, where it states that if FEV1 is nothing but forced expiratory volume in the first second. If FEV1 is more than 1.5 liters, then that patient should go for lobectomy. But if FEV1 is more than 2 liters, then very well you can consider that patient for the removal of the entire lung, which is pneumectomy. Basically, the FEV1 should be more than 80%. So this is the direct statement. But there are lots of physiology into it. But I would like to give you some basics. Okay. So before resection, you just have to assess the functional status of the lung, that part of the lung which will be left out after resection. Say, for example, you're planning for a lobectomy or that part of a lung is being removed. Then what will be the residual functional status of the residual lung? So that has to be assessed preoperatively. And that's done with a spirometry. So this is a digital spirometry where you can see this. You have a mouthpiece into which the patient is asked to blow in and blow out, say for around 6 to 10 seconds. And it's been recorded and the report is instantly out of this machine and you stick it to the patient's case sheet and that's it. It will do. But there are a lot of measurements available to assess the physiological status of a lung. But out of all those measurements available, there are two important, at least you must know what are those two and the definition of two. Understand something about those two like measurements or parameters. And they are FEV1 and DLCO. So FEV1 is forced expiratory volume in first second and DLCO is carbon monoxide diffusing capacity. Okay. So you also need to know FVC. So what is this FVC? Forced vital capacity. So you ask a patient to take a deep breath so that it attains a maximum point of inspiration. So no more air can be put into his lungs. Okay, no more air can enter his lungs. So such is the maximum point of inspiration is reached. Now you ask the patient to exhale out forcefully. So the amount of air that has been exhaled out after the maximum point of inspiration is forced vital capacity. And whatever the air that got exhaled in the first second is forced expiratory volume in first second. So that is all about the definition of FEV1. Now, there are certain situations where you have to consider this ratio FEV1. Most of the, even in SOFA score, to assess the respiratory function, you take this score, right? A ratio. FEV1 is to FVC ratio. So it basically used to differentiate the obstructive and restrictive lung disease. See, in obstructive lung disease, the problem is in the expiration. So the patient can normally inhale, but the emptying of the lung becomes a problem. So problem in expiration. So here, normally FEV1 is to FVC ratio is more than 80% for normal individuals. But if it is somewhere less than 70%, then you should suspect obstructive lung disease. Similarly, in a restrictive lung disease, here the problem is with the filling of lungs. Inspiration itself becomes a problem here. So the patient have problem with inspiration. And see, when whatever goes in itself is less, then what comes out of whatever entered is also less, right? So here the ratio is normal. So it's fishy, right? When it is normal, so when this ratio comes out as normal, it should be either in a normal subject, a normal patient, or the patient should be a restrictive lung disease patient. So how will you differentiate between a normal and a restrictive lung disease patient is that you should look into the individual values. For a normal patient, yeah, the ratio all I have told you, but the individual values, when coming to the individual value, the forced vital capacity for a normal patient is 4 to 4.5 liters. Whereas for the restrictive patient, it drops down to somewhere 2 to 2.5 liters. So when whatever goes in itself is reduced, then what comes out of it is also reduced. So proportionally it reduces. So that's the reason for the normal ratio in restrictive lung disease. Now, when you look into the individual values, then you will come to find out like whether it's a normal patient or a restrictive patient. Now, let's discuss this graph, which was taken out of a spirometry. So this is basically done in a normal patient. So don't panic, it's very simple. So the x-axis is time in seconds and the y-axis is lung volume changes in liters. Okay. Now you ask the patient to take a deep breath. So normally inspire and the point of maximum inspiration is reached. And then you ask the patient to exhale out. So that's the fall. There is a fall drop of the graph starts. It depicts the fall. There is expiration. So this whole volume is the forced vital capacity of the lung. So that goes into the denominator. So see, this is 4 liters. So 4 liters goes into the denominator. Now what comes into the numerator is, this is the whole volume expired after maximum inspiration, which is 4 liters. Now this is the volume expired in the first second. Are you getting me right? So this is the volume exhaled in the first second. So this is somewhere around, say, uh, 3.2 liters. So this is 3.2 liters out that goes into the numerator. So 3.2 liters out of 4 liters is being exhaled in the first second. And when you calculate the ratio, it comes around 80%. Got it? Very simple. So this is normal. Now coming to an airway obstruction patient. The image looks more or less similar, but also only in the size of the graph varies. Even though you can see, it's the same thing here. You ask the patient to take a deep breath, a point of maximum inspiration have occurred, and then you ask him to exhale out. See, the maximum point reached is around somewhere around 3.3 liters. See, 3.3 liters and 4 liters is normal. 700 ml doesn't make a great difference. But when you look into an average, like when you take this ratio, however, there will be a great difference. Now let's go into it. So it's around somewhere around 3.3 liters. So whatever goes in itself is reduced. So it's somewhere 3.3 liters. Total forced vital capacity, totally expired is 3.3 liters. What comes out in the first second? See, it's somewhere around here. So it's here 3.3. So here 2.3. So it's somewhere around, this accounts for around 1.6 liters. Okay. So this is the volume of air that has been exhaled in first second. So now take the ratio 1.6 liters or 1600 ml divided by 3300 ml. Now this ratio comes as 47 or 48%. See how like there's a great difference in this ratio, right? So that is why it's very important to take this FEV1, that is expired volume in first second, to the total expired volume. So that though there is not a great difference in the lung volumes individually, but when you take it as a ratio, there is a great difference. There was 80% and it's only a 47%. So this depicts a airway obstruction. So I hope it's clear for you all. This is the same image, like the same graph, the same concept, except for the x-axis is time and the y-axis is lung volume in liters. But see here, it's the markings are done in the reverse direction. 0 is on the top and it's maximum up to the 6 liters. So just because of the reversal that had happened here, the graph is also, the direction of the graph is also upside down, that is reversed. But the concept remains the same. See here, in a healthy subject, what is the forced expiratory volume? The expired volume in the first second is 4 to 4.5 liters, which is quite normal. And this is the volume that has been exhaled in the first second by a patient with obstructive lung disease, which is around 1.5, 1.6 liters. So the concept remains the same here. So at least you must know this physiology. Okay. Now next, coming to our next parameter, which is DLCO, that is diffusing lung capacity, carbon monoxide diffusion capacity by our lungs. But actually, we have to measure the oxygen diffusing capacity, isn't it? Then why are we calculating the CO, carbon monoxide? So we all know that the hemoglobin's affinity for carbon monoxide is 100%. So when something is 100%, then that will be easy for taken into calculation. Right? To calculate anything, it will be very easy when something is having 100%. So simply by taking some other serum samples also, it will be easy to measure. Whereas oxygen diffusing capacity is not so, isn't it? So basically, to find out the oxygen diffusing capacity, what are the measurements you need is the alveolar partial pressure and the partial pressure of oxygen in the pulmonary capillary blood and rate of oxygen uptake. But all of this are very difficult to calculate directly. So that's why you ask the patient to breathe in carbon monoxide, and you obviously know that the carbon monoxide, so now this reaches the alveoli and you know that the affinity is 100%. So easily the carbon monoxide gets it's very easily soluble into the hemoglobin and in the blood. Now the other fact you have to know, the fact which you have to know is that since the affinity for the hemoglobin is 100% for carbon monoxide and is easily soluble, the pressure difference of this carbon monoxide across the respiratory membrane is equal to the partial pressure of the alveolar air sample. Got it? So the pressure difference of the carbon monoxide in the respiratory membrane, it's actually equal to the partial pressure of the alveolar sample. And from the all those things, you have a formula to calculate this carbon monoxide diffusing lung capacity, which is a volume of carbon monoxide that has been absorbed in short period divided by this alveolar partial pressure of carbon monoxide. So you know that these both are equal. So you apply it in this formula and you get some value. That's it. So this has been done in a normal patient. Now, how will you convert whatever you have, the value you have got is for the is the diffusion of the carbon monoxide. Now, how will you convert the same for the oxygen? One more fact is that the diffusion coefficient of oxygen is 1.2 times that of carbon monoxide. So whatever value you have got it for carbon monoxide, you just multiply it by 1.2, then you get the oxygen's diffusing capacity. So say for example, an average young man at rest will have DLCO of 17 ml per minute per mmHg. Now what will be the oxygen diffusion in this patient? It's very simple. 17 into 1.23, you get it as 20.9. That is approximately 21 ml per minute per mmHg. So these two are the important parameters you have to know. And if you feel like, especially those who are interested in CTVS, if you feel like you need to get some more insight into it, I would suggest that you refer to this Schwartz book, page 692 or 694, or Sabiston surgery or Spencer surgery of the chest. So that this is some of the basic physiology which I can put into you right now. So, but there are really lots of physiology into it. So the direct statement was that if the FEV1 is more than 1.5 liter, then you should only go for lobectomy. But if it is more than 2 liters, then you can consider removing the entire lung. Pneumectomy can be considered. Okay. Now coming to the final question, which is true about guidelines for prevention of surgical site infection? So which of the following is true regarding the guidelines for preventing SSI? So first option is surgical antibiotic prophylaxis administration need not be prolonged or should not be prolonged after completion of the operation. And the second option is mechanical bowel preparation alone, that is without oral antibiotics. It should not be given in adult patients who undergo elective colorectal surgery. So only mechanical bowel preparation should not be given. So that is statement B. And third option is in any patients undergoing surgery, hair should not be either removed or if at all it's absolutely necessary, you remove by a clipper. And for finally, it's all of the above. So at least you should know that two of these are surely right or two of the options are surely wrong, not or wrong. Only then you can arrive at an answer, isn't it? Now, yeah. In Sabiston states, especially the clinical practice, there is this clinical practice of guidelines which gives you some recommendations regarding the antibiotic prophylaxis, all such things. So there are like it's basically based on few core principles which considers two things or two entities. Like one is choosing an appropriate antibiotic, and the other one is proper timing of the first dose, and then will you redose it. Like after how much duration will you redose it? So these two are the two considerations that are mainly taken for this, upon which this clinical prophylaxis or the like recommendations for this prophylactic antibiotics are being decided upon. So how will you choose this antimicrobial agent? Very simple. Say in a clean surgery, there is no threat posed by any microbes except for this skin microflora like Staph aureus or the coagulus negative. And for the clean contaminated surgery, which is class 2, where you operate with controlled spillage of this contents like abdomen contents or any hollow viscous, you just have to give antibiotics which would cover a gram-negative organisms. That's it. So in these two conditions, mostly they don't need the continuation of the antibiotic. And the most commonly used antibiotics are cefazolin, cefoxitin, cefotetin, and vancomycin. All these are the cephalosporins, first and second generation cephalosporins. And the most common among this is cefazolin, which is most commonly used. It's most commonly used. Why? Because of its duration of action. It acts for around 2 hours. But if a patient has labeled with labeled or culture positive MRSA colonization within him, in such case, we can consider giving vancomycin as a prophylaxis. Okay. That is all about choosing a antimicrobial agent. Now, what is an important thing that you have to know about this timing and duration is that the antibiotics have to be given either within 30 minutes of incision or 30 to like a half an hour to 1 hour before you start, before incision. So that is a standard one, you know that. And when will you redose it? And why have to you redose as an antibiotic is that to maintain the therapeutic levels. So unless otherwise indicated, you need not give a second dose of antibiotic prophylaxis. So when it is indicated, see, redosing is done only to maintain therapeutic levels, and when it is indicated is that if there is a prolonged surgery going on, and then for every 2 half-life of that particular antibiotic which you gave earlier, then at that time you need to redose, like repeat the prophylactic antibiotic. So for every 2 half-life of that particular antibiotic, you need to repeat the and dosing, especially in a prolonged surgery. And next is when there is a blood loss of more than 1500 ml. So when there is a blood loss of 1500 ml, the blood that is containing the antibiotic is already lost. That is why you have to replace the like redose the antibiotic when there is more than 1.5 liters of blood loss. So you got me right. And again, Sabiston clearly states that the duration of this antimicrobial administration, it should be limited to the minimal effective length appropriate for for each procedure. Hence, the first option is right. What was the first option? That the antibiotic prophylaxis need not be given after the completion of surgery. Yes, because the duration, it should be limited of the administration of the prophylactic antibiotic is limited to the minimal effective length. And also, most of this clean contaminated operation, they do not require post-operative medication unless otherwise it is indicated. So if at all it is indicated, you can like prolong it to less than 24 hours after surgery. Whereas in a cardiothoracic surgery, the prophylaxis can be maintained for up to 48 hours after surgery. And also there are certain definitions given in Sabiston like unnecessary antimicrobial use, inappropriate antimicrobial use, and suboptimal. So let's see one by one. What is unnecessary antibiotic use? So usually antibiotics are given for bacterial infections. But if you prescribe an antibiotic in a setting of non-bacterial infections, then it's unnecessary use, right? And also if you use an antibiotic beyond the indicated period without indication, then that is also unnecessary. And say initially, like most of the time, you don't wait for the pus culture sensitivity. You just start away with an empirical antibiotic, and then you wait for the pus culture report. But upon receiving the pus culture report, if you don't narrow down this empirical treatment to a single antibiotic, then that is also defined as an unnecessary antimicrobial use. Next is inappropriate antimicrobial use. Yes, inappropriate is if the pus culture, like a pathogen has proved resistance to particular antibiotic, but still if you continue using that antibiotic to which that pathogen is resistant, then that is inappropriate use of the antimicrobial, like antibiotics. And next is suboptimal microbial use. So this is where you like in a conditions or in circumstances which necessitates the use of higher antibiotics, but you are giving some lower antibiotics, then it is inappropriate, not inappropriate. It's a suboptimal administration, right? Suboptimal use. You have to step up to a higher antibiotic. So instead, you continue giving this lower antibiotic, so which is a suboptimal use, or otherwise the inappropriate drug route or the dose is not adequate. All these are comes under this suboptimal antimicrobial use. So that completes the explanation for our first option. So which is true, right? Now coming to the second option. So again in Sabiston, it gives recommendations for appropriate microbe use and at what time it can be given and when should you redose it. In this tabular column, you can find this final last sentence, which states that for any patient who are undergoing colorectal surgery, the prophylaxis of erythromycin, that is oral antibiotic, like erythromycin-based oral antibiotic, must be used in conjunction with mechanical bowel preparation. So it's a direct statement from Sabiston. Got it? So any colorectal surgery, only mechanical bowel preparation is not only that will not do. You should always supplement that with the erythromycin based. So that is the proper recommendation. So second option is also true. Now coming to the third option regarding the hair removal. So this has been already discussed in one of the previous discussion. Again, I'll just read it for you. So again, in Sabiston, there are certain projects undertaken by various centers just to study just in the motto of improving the quality or the post-operative quality and also to prevent surgical site infection. And one such project is the SKIP project, which stands for Surgical Care Improvement Project. And let's see the major initiatives taken by them. So to reduce the incidence and impact of SSI, it's very appropriate to give timely administration of antibiotic, and also you should maintain a proper glycemic control. Usually it's less than 200 milligram per deciliter. And hair removal by clipping and normothermia should be maintained, and appropriate removal of Foley's, otherwise it will lead to UTI. And to reduce the incidence of perioperative cardiac events, you should continue beta blockers in patients who are diagnosed with previous beta blockade. And to reduce DVT and pulmonary embolism, use thromboprophylaxis when indicated. Appropriate thromboprophylaxis have to be indicated. An important point to note here is that none of these individual measures, if done individually, will not give you a positive result. Like all of this mentioned, all of the initiatives that is being taken by the SKIP project have to be used in conjunction with one another. Say, for example, if you don't maintain a glycemic profile, like the patient's glucose is around 300 or somewhere, but still you give an antibiotic, appropriate antibiotic is being given, but that will not do. We have to use all of these measures in conjunction with each other. Individually using one or two will not help you out. Got it? Now, again, coming back to our question. So first option was surgical antibiotic prophylaxis administration should not be prolonged after completion of operation. Yeah, it is not needed. So that's right. Second is mechanical bowel preparation alone should not be used in patients undergoing electrocholysis again. So without administration of oral antibiotics, mechanical bowel preparation only will not do. The recommendation itself is to use it both in the conjunction. And third is patient undergoing surgery, if absolutely necessary, hair should only be removed with a clipper. Yes, that is also true. So I would like to give you the option of all of the above. So this completes our discussion of the general surgery questions that appeared in the NESS. So finally, I would like to stress 2 points. Just revise all the tabular columns, important tabular columns in the Bailey and Sabiston latest edition. And coming to the critical care, you must be thorough with the updated versions of the ATLS and such things. And whenever you encounter any calculation-based question, don't forget to recall any kind of basics or concepts behind that question, because the examiner doesn't want us to simply calculate over a formula. That must be some concept behind all those numerical questions. So that is all I want to stress you right now. Stress you all. So all the very best, friends, for your exams. Thank you.